Hello and welcome to this training video on working with patients who self-harm, challenges and implications in practice. The objectives of this training are to look at a definition of self-harm, to get some more understanding of the behaviour behind it, to look at some statistics, and then to discuss some challenges in practice, the impact on staff and implications for practice and interventions. This is specifically aimed at those who are working in a general hospital. So what is self-harm? Self-harm is self-poisoning or self-injury irrespective of the purpose of the act. It's a coping mechanism and not a mental illness in itself. Self-harm can include anything from cutting, burning, ligature tying, head banging, swallowing foreign objects, or insertion of foreign objects inside the body. So why might somebody self-harm? Self-harm is an unhealthy coping mechanism. People self-harm to try to manage their emotions, and it provides a means of escape from uncomfortable feelings that they aren't sure how to process. It can provide a release of anger, tension or frustration. It's also an act of self-punishment for many people, for those who may have perception of needing to be punished. It provides a rush of endorphins. Some people say that they feel numb and self-harming helps them just to feel something, even if that might be pain. And self-harm is extremely addictive. There can for some be a ritualistic behaviour to self-harming. People who self-harm might find the act of cleaning a wound and tending to an injury as part of some unconscious self-soothing process. There are also other unconscious processes at play for patients who are, for example, repeat self-harmers, who may, on some level, conscious or unconscious, find comfort in having their needs attended to and their needs met by care staff. It provides a sense of safety and a security which they likely do not feel or have never felt anywhere else in their lives. This diagram is known as the cycle of addiction, and this one has been specifically designed to represent the psychology behind the behaviour of self-harm. It can also be used to understand why people might abuse drugs and alcohol. So the red arrow starts with the negative emotion, which, let's take for example a fear of abandonment or a fear of rejection, or a perceived fear of abandonment or rejection. This then causes a build-up of tension and the uncomfortable emotion. The person isn't sure how to relieve or find any means of processing that emotion, which then can lead to an act of self-harm, which provides a release of endorphins. The person is then often left with a feeling of guilt, shame and remorse over the self-harm, but the guilt and the shame and the remorse is also a negative emotion, hence why they get stuck in this cycle. And it can become progressively worse over time. People may not find the same relief from the ways they used to self-harm as the ways they find relieving now. Similar to those who are using drugs and alcohol, they build up a tolerance, so they have to drink more, they have to take more drugs. So if we take a patient who cuts, they may have to cut deeper to find the same relief. So on what point do we think that we would be looking at providing an intervention to break the cycle? Well, this could be in many areas. We may look at the negative emotion and in between the build-up of tension to try and encourage the person to find more healthier ways of managing that negative emotion and understanding the emotion better, being able to identify it better and then know what to do with it or how to sit with it, because we all experience negative emotions, but it's about learning ways of coping with them. I do feel it's hugely important to talk about the damaging impact that social media has had on self-harm for young people who are extremely vulnerable to these pro-self-harm websites and pro-suicide posts. And I've certainly seen more of these social media contents appear over the years. They get locked down, but more are started up. I don't know if anybody knows this girl, Molly Russell. She was 14 years old and she committed suicide on one night after school on a seemingly normal day. And investigations into her death uncovered that she had been following these hashtags on Instagram and Pinterest related to self-harm and pro-suicide. Pinterest has a feature when it suggests to you links or other pictures that you could look at based on your recent searches, and Pinterest was recommending, in Molly's case, more posts and more content about suicide and self-harm. You know, young people are very vulnerable because they're still developing a sense of identity, they're not sure who they are, and they can get lost in this online world. So, some statistics. Non-suicidal self-harm in England has nearly tripled over the past 10 years, which was found in 2019. So non-suicidal self-harm refers to self-harm without the intent of ending your life. There's higher rates amongst women, but men are more likely to be at risk of actual completed suicide. And it can affect adults as well as young people. Many people start in their teenage years and it can progress into adulthood. In 2014, 6% of people had self-harmed, up from 2% in 2000, with the highest rate in those aged 16 to 24. Basically, this is just demonstrating that, you know, sadly, this has increased. And in the UK, there are around 200,000 general hospital admissions for self-harm. Why do we need to talk about this, and why do you guys, as those working in general hospitals, need to understand this? This patient group are particularly vulnerable. They are prone to accidental death, a prolonged admission, and restrictive practices such as increased supervision, the use of the Mental Health Act. These patients are often subject to stigma and negative attitudes from staff. And it's part of a wider suicide prevention strategy because people who self-harm are statistically more likely to then go on to attempt suicide. And these patients are often more likely to present to general hospitals first before mental health services. And it's really important that we get it right at this first point of contact, because if they have a bad experience, this might lead to them disengaging with services altogether. It's important to recognise that there are challenges faced in clinical practice when we work with these patients who self-harm. For many staff, patients who self-harm can be extremely challenging. Patients who self-harm can be emotionally demanding, and we're only human after all. There is, as we know, a lack of training for staff, but it's important to note that research suggests that positive care is not linked to knowledge of self-harm, but expressions of kindness from staff. Patients report facing stigma and hostility from hospital staff, which then leads to feelings of guilt, and they feel looked down on, and they feel like they're a burden to the healthcare system. It's really difficult to manage self-harm risk in a general hospital. Mental health services are, as we know, hugely under pressure. The threshold is very high to get any support. These patients are more likely to self-discharge or abscond, particularly if we haven't managed to get that point of engagement with them. And we know that there is a lack of time for these patients, but I would say that even 2 minutes, 5 minutes of your time can go a long way. We are only human. Patients can evoke strong feelings in us. This is called transference, particularly where there might be high emotions in treating patients who self-harm. There are lots of conscious and unconscious processes at play, which in psychiatry and mental health services we call countertransference and transference. More importantly, Non-mental health trained and mental health trained staff can find some patients very challenging and frustrating. There's a fear of the unknown, perhaps. Staff can feel powerless and the high emotion can be triggering. They might be reminded of their own personal experiences with self-harm, or perhaps a relative or a friend suffers. And there's no obvious quick fix for self-harm. There's no specific guaranteed to be effective treatment or medication. Often the person might have no desire to change and no willingness to stop. And we cannot force patients to recover from self-harm. This is their own journey and their own process. Ultimately, we are powerless, and this can be really frustrating for staff. And sometimes these feelings of frustration can cause staff to lose control of their emotions, and this can have a big impact on somebody's care. But we will go on to look at some ways that we might be able to help somebody and some things that we can do to look after ourselves. Implications for clinical practice. We certainly need a change in attitudes. And I will say that this is not only in general hospitals. You do find a lot of stigma and attitudes that are negative in nature amongst mental health professionals. This might be linked to compassion fatigue or burnout. A small amount of your time goes a long way. I think it's really important that we work towards improving our awareness of self-harm so that staff can see the person and not the behaviour. By improving awareness of the reasons why that person is self-harming and challenging assumptions that they are attention seeking, we can then have more empathy and more understanding. In an ideal world, I would believe that it's important that staff have access to some form of clinical supervision, which I know isn't always going to be achievable. But it should be achievable to always have a point in the shift where you can discuss with somebody how a patient might have made you feel, or what you'd do differently next time, what went well and what didn't go so well. The staff can feel a lot more supported in this way, and this can bring a reduction in staff anxiety. And this could lead towards more focus on reflective practice. Keeping reflective diaries is something that many mental health nurses do, particularly when they're involved with very triggering patients. It's also really important that we involve patients who self-harm in decisions about their care, because we're giving back the power to them. We're asking them to work with us, and this removes that feeling that they can have about powerlessness. People not involving them in their care, them not knowing what's going on, can make them feel quite frustrated, and their emotions are going to be heightened. What can we do to help? We should see the person at all times, not just the self-harm behaviour. We should ask ourselves, why is this person self-harming? Do we even know or understand what their past experiences have been, or what led them to choose this behaviour to manage emotions? And even so, who are we to judge until we've walked in their shoes? Allow the person time to talk about their feelings, even 2 or 5 minutes. Be a human being, validate emotions, convey to them that you respect their feelings and you also appreciate them sharing these feelings with you, and be open-minded to their experiences, ask questions and check your understanding. Talking is effective. We may not need to say anything, but listening can be a very powerful tool. And remember the positive impact you can have in being kind and compassionate. We can always encourage the person to seek help and offer them feelings of hope that they can change. We should make time for reflective practice. And as always, stigma related to mental health continues to be a huge issue, and we should challenge stigma. I hope this has been useful for you. These are some examples of websites and support lines that we can be guiding our patients towards. There's loads of online resources and self-help for managing self-harm. There's the Samaritans helpline, a fantastic 24/7 service for people who are feeling suicidal. This app to the right, Stay Alive, is a free app that patients can download, or anyone can download, and it includes a safety plan, which is basically used to help somebody manage their personal safety when they're feeling at risk of self-harm. They can go on and use distraction techniques and try and find other ways to manage that emotion. Thank you for watching.